Hello, my name is Arya Javidan, and I'm the project manager for the National Consortium of Telehealth Resource Centers. Welcome to the latest presentation in the NCTRC webinar series. Today's session is on leveraging telemedicine to eliminate outcome disparities for rural-born newborns. Today's webinar is hosted by the Northeast Telehealth Resource Center, and these webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. Just to provide a little bit of background on the consortium located throughout the country, there are 12 regional telehealth resource centers and 2 national, one focused on telehealth policy and the other on telehealth technology. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. Just a few tips before we get started. Your audio has been muted for today's webinar. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Please note that closed captioning is available and is located at the bottom of your screen. Today's webinar is also being recorded, and you will be able to access today's and past webinars on the NCTRC YouTube channel. And with that, I will pass it over to Danielle Lauder, Director for the Northeast Telehealth Resource Center.
Thanks so much, Arya, and thank you so much to everybody who is able to join us here today. We have a great session planned. And without further ado, because I want her to have the most time possible to share this amazing program and outcomes with you, I'm going to quickly introduce our colleague, Dr. Alexa Craig, who is one of our unicorns in our region that we so greatly appreciate her passion for this. But Dr. Craig is a neonatal and pediatric neurologist at Maine Medical Center and Maine Medical Partners, a clinical researcher and director of the Barbara Bush Children's Hospital Scholarship Academy. She's originally from New England, and we are so thankful that she's stayed here with us and brought all of her talents. Attended the University of Vermont College of Medicine for her medical degree, followed by 2 years of pediatric residency at Maine Medical Center and a residency in child neurology at Washington University and Seattle Children's Hospital. She did an additional year fellowship in neonatal neurology at the University of Washington and St. Louis Children's Hospital. In 2012, Dr. Craig returned home to Maine Medical Center to start her neonatal neurology program and academic career. Following her return to MMC, she was the recipient of a KL2 Career Development Award through the Tufts University College of Medicine and obtained a master's degree in clinical and translational research. And that's going to lead her into the program that she's going to tell us about here today. So I'm going to go ahead and let her describe that. But thank you so much for being with us here today, Dr. Craig, and we can't wait to hear from you.
Thank you, Danielle. I'm a little embarrassed. That sounds way too fancy. Okay, so audio's good. Everything you guys can hear? Good.
It's perfect.
Perfect. Okay. So I would love to be from Maine eventually, but I was actually born in Vermont, so all I can claim is being from the Northeast. But as everybody probably is aware, we're a pretty rural part of the country. And so when I made the decision to come home to Maine and practice here, I was sort of faced with this very large geographic area and wanting to make sure that babies born in rural parts of the state had the same opportunities as babies born in the tertiary care center that I work in. So that's what I've really been spent the last 10 years, trying to work on. So just a couple of disclosures. Some of the projects that I'm going to tell you about were funded by the Northern New England Clinical and Translational Research Network. And that was some of the first early grant funding I had. And then after that, we got an acute care rural health COBRE grant that also funded some of these projects. And then I always give a shout out to families who have been so generous with their willingness to participate in research so that we can, further this telemedicine adventure that we're all on. Quick objectives for the talk today. Want to talk about optimal care for a problem called neonatal encephalopathy or hypoxic ischemic encephalopathy. I'm not expecting this audience to necessarily know exactly what that is, so we'll go through that quickly. And then I'll tell you about strategies that I've implemented, including telemedicine, that allows me to evaluate these clinical conditions better while simultaneously improving the patient's experience. And then also in recent years, we've really taken the tele idea of things to a whole new level with how we're supporting rural community hospitals with resuscitating babies who have difficulty immediately following birth. So we'll talk about that at the end. So I just always like to start with this fun fact about the human brain, which is the only organ that studies itself. It's sort of a funny thing. The brain what we call it an energy hog, right? It's only 2% of the body's size, but it actually utilizes 20% of the body's energy because there's so much electrical activity going on all the time. And that high energy need is why babies can get into trouble when they're being born. So in a somewhat flawed design, a baby in the womb has one way in for blood flow that has rich oxygen and, glucose and all the things that a brain needs to be, kind of in a very happy and kind of, positive state. And so if anything happens to that umbilical cord to, occlude the blood flow to the baby, very quickly oxygen levels drop, very quickly glucose levels drop, and the baby doesn't have a lot of reserves to be able to tolerate that for very long. So if that goes on for a certain period of time and causes injury to the brain of the baby, we use the term hypoxic, meaning lack of oxygen, and ischemic, meaning lack of blood flow. And encephalopathy is just the term for the fact that this is happening to the head. So HIE is the diagnosis of, brain injury from lack of blood flow to the brain. In a developed country like ours, the estimated incidence is about 1 to 3 per 1,000 live births. So in Maine, where we have about 12,000 babies delivered each year, there's about 36 roughly, incidences of hypoxic ischemic encephalopathy. And the reason we care so much about this disease is that it's associated with really profound long-term developmental consequences, such as cerebral palsy, hearing impairment, vision loss, and seizure disorders, amongst other issues. And we know that the lifetime cost of children who have cerebral palsy are somewhere in the order of, $16 billion, which is obviously, these are very expensive conditions to have. So I'm going to go through a case right now with you and kind of just show you what this looks like and, kind of how HIE is recognized and what we can do about it. So this is a little guy named Aaron, and his mother and father kindly allowed me to share pictures and share his story. So Aaron has 2 older brothers. His mom had a completely healthy pregnancy, and she delivered him right around his due date in a rural community hospital here in Maine. And as she was laboring, her water broke and the umbilical cord came out before the baby was born. And that's, as you can imagine, sets this baby up for compromised blood flow because the placenta can't push the blood through the umbilical cord when it's outside the womb anymore. So this poor mom had a stat cesarean section with general anesthesia. As you can see here, hopefully you can see with me moving my cursor, little Aaron has bruising on his chest where he was having chest compressions because his heart wasn't beating when he was born because of the oxygen deprivation. And it took the pediatrician in the community hospital 4 times to successfully put a breathing tube into his airway. What we do is we measure the level of acid in the baby's blood. We get the blood out of the umbilical cord, and we use that as a sign of whether, kind of how long the baby's been without oxygen. And so this pH here of 6.8 suggests that the baby has been without oxygen for quite a long time. Obviously not enough time to cause him to pass away, but enough time to cause us to be very concerned about him. What's really exciting about, taking care of children with therapeutic hypothermia in this decade or 1 decade prior is that we now have a therapeutic option for them. Up until about 2005, there was really not a lot you could do for these kids. Since 2005, there's been a treatment called therapeutic hypothermia, which has been a complete game changer in terms of promoting typical neurodevelopmental outcomes in kids with birth stories like Aaron. And so you can see this picture here of Aaron, who is getting the therapeutic hypothermia treatment. And what he's on a cooling blanket. You can see this blanket that he's laying on. And what that does is it regulates his body temperature and decreases it from normal, which is about 98.6 to 91 degrees Fahrenheit. And we do that to him for 3 days to allow the brain, the swelling in the brain, and maybe if there's any seizures, to allow that to all calm down. And it's a lot like, you conceptualize it as like putting ice on an ankle that you sprained. You want to kind of cool it off and let the healing happen. So this is just another little friend. This guy's named David. Another picture of a cooling baby where I can go through all the bits and pieces of it. So We put EEG leads on babies' scalps so that we can measure brainwave activity and see if they're having seizures. We put IVs in their hands so that we can draw blood or give them antibiotics or other medications. They also have IVs in their belly buttons to make sure that we can measure their blood pressure. They lay on this cooling blanket here, which is the cooling blanket is regulated by this temperature probe that's in the baby's nose. And then we measure their heart rate all the time while they're on this treatment. So it's a very intensive therapy, as hopefully this picture explains to you. So the good news for Aaron is that the EEG leads that were on his head recorded no seizure activity throughout the whole 3 days of cooling. And we did an MRI of his brain upon completion of cooling, and it was completely normal. This is what a normal term baby's MRI looks like. And he went home on day of life 11, and he was feeding completely by mouth, and for all intents and purposes looked like a completely normal baby. And here he is at about age 18. I can't remember if it's 18 months or 2 years, but he continued to be a completely normal kid. And of course, we can't go back in time and find out what would have happened if he was not recognized as a candidate for this therapeutic hypothermia treatment. But I like to think that him receiving the treatment had a role to play in this typical neurodevelopmental outcome. So I thought a lot about Aaron's case over the years, and I thought, what was the role of chance? Why did he get a good outcome? And other kids arrived in my NICU where they stayed in the community hospital. The pediatrician didn't call us to say, hey, we have this baby we're worried about. And then they start seizing like crazy when they're a day old and they can't be cooled. I think I forgot to mention that the cooling treatment has to start by the time you're 6 hours old. Otherwise, it isn't effective. Okay. So I thought a lot about this, idea of chance. And, hopefully people on the call here have heard about this Swiss cheese model of organizational accidents. The idea being that certain factors have to all align kind of perfectly for an accident to happen. In this case, I think of it in a similar way. Certain factors aligned for Aaron that allowed him to have a good outcome, whereas that wouldn't have normally happened in my hospital. And so in this community hospital. So one of the factors was that he was born first thing in the morning. And so the pediatrician was able to be at the bedside with him in the first 10 minutes of life. Sometimes pediatricians can't get there for like half an hour or more. Although it was difficult for her to get a breathing tube in him, she was ultimately successful after 4 hours. After 4 attempts. And so she was able to get his oxygen levels up fairly quickly. And then most importantly, she knew about therapeutic hypothermia. So she called the tertiary care center and we were able to get to Aaron very quickly and start him on the hypothermia treatment, actually in the ambulance coming back to our hospital because we had recently purchased through philanthropy a device that allowed us to cool on transport. So there were all of these benefits that kind of aligned to help Aaron have the best treatment at the best time. The other thing that was helpful was we deal with a lot of snow here in New England, and it wasn't midnight and it wasn't a snowstorm. So we were very lucky to be able to get him, quickly and bring him back to Maine Medical Center. This slide is here to just sort of highlight how rural Maine is. So you can see, all of these green areas across the top of our state have less than 1 person per square mile. I live down here in this Red Star area where there's more than 5,000 people per square mile. This is where my tertiary care center is. And then we have one other tertiary care center up here. So we in my hospital tend to serve this region. And then this hospital up here where I also work serves the whole kind of top part of the state. And we are getting babies in transport from community hospitals where there's often less than 1 baby born every single day. And so what that means is that the clinicians who work in these hospitals are just not getting a lot of babies and they're not getting a lot of experience, certainly making the decision about hypothermia or not. So this is just to a fun picture to show, the ambulance that we use to, this is a neonatal nurse who goes out on transport to get the babies and bring them home to the tertiary care center. And this is another little patient of mine who was treated with hypothermia. So this is kind of just a chart of how many babies we've cooled per year. And I think the chart kind of shows an interesting story. So we cooled our first baby ever at Maine Medical Center in 2008. And you can see that the numbers were kind of low, nowhere near the 36 that we were expecting based on the birth rate of Maine. And I think the reason for that was that only the most severe babies were being recognized as eligible candidates for this treatment. And so, I when I came to Maine Med in 2012, when I finished my last year of fellowship, I went on this educational campaign around the state, and I gave people lots of brochures and lots of information. And the other thing that I did was I started this database and recorded the actual clinical data of every baby that had been treated with therapeutic hypothermia so far. And there were a lot of interesting realizations that we had from this database. And, maybe, not to get too in the weeds with the science here, but just looking at deaths from hypoxic ischemic encephalopathy, what we realized was that half of the deaths were coming from the very small volume hospitals. So there were fewer babies coming from these hospitals, yet the biggest proportion of the deaths were coming, from these small hospitals. And when we looked at the characteristics of, mothers from the tertiary care center versus the small hospital, or the babies, like the size of the babies, the gestational age, all of these things, the babies born at the tertiary care center were being born to mothers with more active medical problems at a younger gestational age. And that should have been the cohort with a higher rate of death because they were more complicated pregnancies. And instead, what we were seeing was this high rate of complications, either MRI injuries, seizures, pulmonary hypertension. These are coming from the healthier side, or what should be the healthier side of the cohort, with older gestational ages, higher weight babies, and less complicated mothers. And so we felt like this was really backwards from the way that it should be. I had wonderful help from a statistician who helped me, kind of create models and kind of run this. And the long and the short is, if you were born in a small volume hospital, which we defined as a birth rate of less than 500 babies per year, your odds ratio of having either death or a severe brain injury were 5.9 times higher than if you were born in a medium or large volume hospital. And then when we did the stats and we adjusted for things like maternal age and gestational age, that relationship strengthened, and you were 7.5 times more likely to have that bad outcome of death or severe brain injury. So, kind of going back to what we wanted to do about this, the first idea we had was to educate people. And so we put these time is brain posters all over the state in every newborn nursery. And one is for the NICU here in the southern part of the state, and this one is for the NICU in the northern part of the state. So we had sort of similar brochures, but different phone numbers. And to walk you through this really quickly, it's kind of like the asthma action plan. If you have a baby that meets the criteria in the red line, call immediately. They probably have to be transferred. If you have a baby in the yellow, kind of zone, not sure, call and talk to us. We'll figure it out together. And then if you had a baby in the green zone over here on the right, probably they don't need any help from the tertiary care center. And so what happened after that educational, after the database got started and after the educational outreach, our numbers, as you can see, skyrocketed. So we had 43 babies that we cooled in 2015 and 39 babies in 2016. And while I was pleased that we were cooling more babies, it seemed like now what we were doing was just reflexively cooling babies. If, for instance, there was a low pH on the blood gas, or, if the APGAR score was low, like if there was anything wrong with the story, the answer was to cool. And as I mentioned, it's a fairly invasive therapy. And so we didn't want to be doing that unnecessarily on babies. So basically what was happening was there would be a family medicine doctor or a pediatrician who would stabilize the baby in the community hospital. They would call the NICU for advice, and it felt like they were calling on a phone kind of this outdated and antiquated. And the neonatologist would be feverishly sort of trying to figure out what time the baby was born, and are we in the 6-hour window, and can I get the ambulance to them quick enough to start? And I think these were things that were driving the decision, just cool it. We don't want to miss it, so just cool it, The other thing that was happening was the pediatrician was trying to describe over the phone how a baby was acting. So in this upper left-hand corner here, I'm showing you a picture of a normal baby who doesn't have HIE, who doesn't have, didn't have a crazy sad birth. And this baby is in a flexed position and he's moving and his eyes are open and he's really normal. This baby in the top right-hand corner is a baby with mild encephalopathy. So her eyes are open, but she's kind of staring off into space and she's not moving, but a lot of other things are pretty reassuring about her. This baby bottom left is moderate encephalopathy. So he's staring into space. He has a breathing tube because he was forgetting to breathe, and he's pretty floppy and low tone and not moving. And then the baby in the right-hand corner has severe encephalopathy. His tone is flaccid. He's not moving at all. And he's on like the highest level of intervention we can provide for respiratory support. So what we tend to do is to cool moderates and severes because there's really good data behind knowing that moderate and severe encephalopathy respond to therapeutic hypothermia. We try not to cool milds because there's no prospective data showing that it benefits them. And again, it's a very invasive therapy. And so when these pediatricians were making these phone calls, it was very difficult to figure out which bucket the kid was in. Usually they're not calling you about normals, and usually severes, they can't transfer those kids fast enough. So it was this mild to moderate, this kind of right diagonal axis that was really tricky to figure out. So in 2017, finally getting to the telemedicine part of my talk, and I'm really proud that we did this way pre-COVID, right? We built this platform where we had one camera in the tertiary care center where we could do consults with me anywhere where I happen to be. So I was the remote consulting neurologist to the tertiary care center. And if I remember correctly, this was VIDYO software that we were using, or no, maybe this was Jabber that we used first. I can't remember. But I had the ability to control the camera with these buttons over here marked E. There was a window that would pop up where I could look at the baby. The nurse would be at the bedside and she would help move the baby, help do the assessment. And then the IT person at this point in time was physically over my left shoulder, but metaphorically, they were always there to help and make this work. And this is what our cart looked like with this fancy camera that we could kind of pan and tilt. And so we ran this study for a year. It was just a kind of a quality improvement study. And what we found were some very important disparities that we could now quantify. So babies that were born in the tertiary care center, if a neonatologist had a question about them, we were able to do the consult around about 2.1 hours of life. Whereas if the baby was born in the community hospital and had to be sent to my hospital for the consult was delayed, of course, till 4.7 hours of life. The other interesting thing, particularly for the babies that were transferred, was that only 36% that were transferred actually met criteria for cooling, which meant that the other 64% had a very expensive ambulance ride from wherever they were born to my hospital. They were admitted to the neonatal intensive care unit, which is also very expensive. And most importantly, they were separated from their parents because the mother is often left at the community hospital to arrive hopefully the same day, but sometimes not for the next day or two. And so what the results of this first 1 year pilot program were not dramatic, but we started to show a decrease in the number of babies that we were cooling because we were weeding out some of those mild kids who did not meet criteria for treatment. So the next iteration of the program started in 2018 with the NNECTR funding and also COBRI funding eventually. This is where we use the video platform because we put cameras now in the community hospitals. And we needed to be able to do a three-way consult between me as a neurologist, this is Dr. Gina as a neonatologist, and then the community hospital in the third window. And so we used this platform for about 2 years, actually. And we collected data on all of the kids again, those born in the tertiary care center and those born in the community hospitals. And we're very pleased to see that in the tertiary care center, the time to first consult went from 2.1 hours to 66 minutes. And in the community hospitals, now that the babies don't have to be transferred for their evaluation, the delay went from 4.7 hours to about an hour and a half, which is a very, very substantial improvement. What's really neat about getting these consults so early is that it allows you to get a second or even a third consult before the 6-hour time frame to really get a sense of, is this encephalopathy getting worse, in which case the score is getting higher, or is the encephalopathy resolving and the numbers getting lower, and then they don't need treatment. So you can see what happened from 2018, where we started doing these community telemedicine consults. Our number really went down to a very appropriate level, because don't forget, there's a second NICU in Maine who is also cooling 15 to 20 babies a year. And so together we're now cooling about 40, and we're really on target for what we know the incidence of HIE to be. So we've done a lot of work with our, with the rural community hospitals to see how we can improve the delivery of this service. So this is a project that was done last year with not even a medical student, a college student who worked for me for the summer. And what she did was she interviewed 17 clinicians from all of the different institutions where we have telemedicine cameras, which is now 10 different hospitals around our area. And in those interviews of the physicians, we did this qualitative analysis, and we found some really interesting and some of these unexpected findings. So it didn't surprise me that a lot of the physicians we talked to really valued the collaboration in the decision-making around to cool or not to cool. They also talked a lot about resource utilization and how wonderful it was to not have to transfer a baby by ambulance if it didn't meet criteria. And they also talked about how amazing it was to be able to push a button, have the camera turn on, and have not one, but 2 pediatric specialists, right there available to evaluate the baby. So those were things that we expected. What I didn't expect, and of course, now that I know this, it's kind of a duh moment, but outside pediatricians were feeling very traumatized when these, traumatic deliveries happen, and they were isolated and by themselves in these small community hospitals having to make these high stakes decisions. And so the existence of the telemedicine program has resulted in a reduced amount of trauma experience for the clinicians, which I think is really important when we think about recruitment and retention into rural areas and having people feel like they can live there and practice there, but still have the support of specialists who can help them when the going gets tough. And then the other thing I think that these pediatricians talked to us a lot about was how much they valued the opportunity to have the access to the ongoing education. So each time we do a teleconsult together, they're learning skills because there's this repetition of the, that's created by the consult. The other stakeholder engagement that we did was to interview parents whose babies had been treated with therapeutic hypothermia, because we really want to have we want stakeholder engagement, of course, from all parties involved. And this actually led to I think I'm up to 5 papers I've published from these data sets at this point. And this is a super busy slide, and I don't want to go through all the themes, but a couple to highlight include the parental experience of trauma, because, these, for the most part, are, healthy pregnancies, everything is going fine. And then suddenly during the delivery, there's bleeding, there's a rupture of, an umbilical cord or a rupture of the uterus, like something terrible happens and everything changes. So you can understand how that can really cause trauma to the family. So anyway, a lot of communication themes are improved with telemedicine, and decision-making is improved with telemedicine. So this is the part where I get to say thank you to Danielle Lauder for her incredible help and coaching. I kind of have exhausted, at least I think I've exhausted what I can do with the telemedicine program that I've built in terms of research. And the truth is it's changed the standard of care here. When we have a consult from a hospital that doesn't have a telemedicine camera, we feel very much like our hands are tied and we can't appropriately evaluate the baby. And so in the setting of that changed standard of care, we needed to find a programmatic solution to use some kind of alternative funding to have this program exist for several more years as we work out how to make it a clinical program that's sustainable in terms of its own billing and its own income. And so we found this HRSA opportunity, or should I say Danielle told me about this HRSA opportunity. I would have never found this without her help. And basically what it is a rural health network development program. And so with a lot of help and hand-holding from Danielle, amongst other people here at the Maine Health Grant Office, we submitted this November 22nd. And the goals of this grant were to improve access, which clearly, this telemedicine program improves access in rural areas. The expanding capacity goal of the grant, what we did was we said, we're going to take what we've done here in the southern part of the state and expand it to the northern cap of the state, so that other NICU will have a hub and spoke model very similar to what I've built here. And then the enhancing outcomes, of course, is kind of a no-brainer, because we're saving children from having an expensive, unnecessary therapy that they don't, that they're not likely to benefit from. And then this sustainability piece is what we're going to work on over the 4 years of the grant funding in order to be able to try to make the program, a freestanding entity of its own. So anyway, so this is kind of like my specific aims for this. So I'm not exactly sure when we'll find out if we were lucky enough to be selected for this, maybe sometime early summer, but fingers crossed. And, again, this is just a sort of a slide to show all of the rural hospitals across the state and how, this proposal has one hub up here at Eastern Maine Medical Center that would cover all of these northern hospitals. And then our other hub would be here at Maine Medical Center in purple, covering all of these southern hospitals. And the other thing that I really pitched in the HRSA grant that we wrote is that there's this band of hospitals kind of right in the middle. And if both tertiary care centers are operating on parallel, like on a same program, rather than kind of silos and doing their own, separate things, then this hospital right here in the middle that happens to have the third highest delivery rate in the state, they can turn the camera on, and depending on whose NICU is full and whose NICU has a bed, they can have a consult with whichever hospital, and it can be seamless for the rural user, which I think is really, I think is going to be a key to making this successful. So, so that's kind of the background on hypoxic ischemic encephalopathy and kind of the cooling and how I've, kind of built this. I always call it my little telemedicine empire. How I've built that to kind of serve my community. I have a new problem now, which is I want to make sure that all of these kids that we are not treating with therapeutic hypothermia, these mild kids, I want to make sure that we're making the right clinical decisions. And so, as I mentioned before, we cool the moderates and the severes, and the milds, especially if they evolve into moderate, we would cool them. But it's really in my field very uncertain right now about what is the best management strategy for these milder kids. And so in 2020, I was lucky enough to receive funding from the COBRE, which stands for the Center of Biomedical Research Excellence. So at Maine Medical Center, we have this acute care COBRE in rural healthcare research and disparities. And so in this grant, what we're doing is we're partnering with 2 other rural tertiary care centers, Northern Light, Eastern Maine Medical Center in Bangor, and then the University of Vermont in Burlington. And what the goal of the study is for a baby to be born who has mild encephalopathy to be transferred to the NICU for a encephalopathy exam at any time of the day or night, vacation, no vacation, done by me for all of these years. And then we make a decision depending on how the neurologic exam is. And either they meet inclusion criteria because they're moderate and they become like this little guy, David, and they get cooled. Or if they're mild and we don't think they will benefit from the therapy, we exclude them, but we get outcome measures. So the outcomes are an MRI of the brain and an EEG of the brain to ensure that we're making the right clinical decisions and we're not missing any babies. And so far, we've recruited 12 babies at Maine Medical Center and no babies at the other 2 sites, but hopefully that's going to change soon. The other thing I wanted to tell you about is the fact that the kind of the decision to treat with hypothermia is only really a part of the story. The other part of the story about how these babies do and how that like Swiss cheese model lines up is how the pediatrician who is there, hopefully right as the baby is being born, what are the skills of that pediatrician to actually resuscitate the baby, put the breathing tube in if it needs it, and how are those skills maintained? And so I've been working with colleagues here who are neonatologists on using simulation to try to improve those skills. And I'll show you a little bit more about that here. So there's this thing called the Newborn Resuscitation Program, or NRP for short. And basically the NRP program was started by the American Heart Association and the American Academy of Pediatrics. And it's updated and rigorously studied. And I'm sure you can't see the details of this algorithm, but this is blow by blow how to provide the very best up-to-date care for a baby who's born who doesn't just start breathing and crying and acting completely normal. And these steps are studied and investigated, and the best practice is to go through the algorithm exactly as it's outlined here. And so what we did was we created an on-site simulation training event. So what happens is the team from the NICU, they go on a road trip. It's not quite as fun as the pictures make it look here, but they take all of this stuff to any of these community hospitals for us in the southern part of the state. And then the team in Bangor does it for the northern part of the state. And what they do is they set up skills stations so that all of the pediatricians in that community hospital and all of the nurses who attend deliveries and all of the respiratory therapists who are there get to sort of like hands-on practice the therapies that they might be giving. So this woman here is practicing bag mask ventilation. This pediatrician here is practicing intubating a preemie, and they're being coached by this expert respiratory therapist who's worked for us, I think, for 30-something years. What we also did was we set up the room where the baby is resuscitated with these cameras that are in the ceiling. And one camera sort of shows you the lay of the land for the whole room, and then the other camera looks directly down on the baby. So this is what you can see if you're not physically present at the resuscitation. You can see all of the people interacting with the baby, and then you can kind of do crowd management of what's happening in the room. And these on-site simulations were recorded using these cameras. And then what we did was we went through and we checked to see, did they do things in the right order? Did they forget to do something entirely? How quickly did they do the steps in the NRP algorithm? And all of that is converted to something called an NRP adherence score. The other thing that we did was we measured confidence of these participating pediatricians and nurses and respiratory therapists before the on-site simulation day and at the end of the on-site simulation day. And this is kind of like a complicated, it's called a violin chart, but you can see the pre-confidence scores, the pre-simulation day conference scores are represented in black, and you can kind of see that they span, anywhere from 2 to 5 to 1 to 5. They're pretty broad, okay? And then after the simulation day, the confidence scores are narrower. They're higher, they're sort of centering more on 4, whereas before they were, lots lower. So we could claim that the on-site simulation training really helped the clinicians feel more confident. Sadly, when we compared their confidence scores to their actual NRP performance, their performance wasn't improving. And so, sorry, I keep getting text here. So the problem with NRP performance not improving is that we've actually made people feel more confident, but their skills aren't improving. And so the delivery room resuscitation won't improve. And this is things, from resuscitation knowledge, airway management, how prepared do they feel to manage a code, the team communication, support and resources and skills of team members. Across the boards, it was the same pattern, improved confidence, but not demonstrating the skills. So it seemed that the answer to the problem was not to go on site more frequently, because that was economically not viable to send a whole transport team out for days at a time to train all these people. So what we started to do was what we called telesimulation. So we left the mannequin there. This is the mannequin, the little guy that does all the stuff. And we left the cameras at the community hospital. And once a month, the team would log on and run the remote or rural hospital delivery room team through a scenario to see if we could improve their NRP adherence scores over time. And so this is what it looks like. So here's the two people, the two neonatologists who are running this simulation, only they're located in Portland. And this is the team doing the simulation in Farmington, which is over 2 hours away. And so what you can see this bird's eye view of the baby here, and then the room kind of crowd control view to see who's doing what there. And what we're so incredibly excited to show is that over the course of 6 simulation trainings, the group performance went from 32, which is their baseline scores at that on-site training, up to a high of 88%. So that means that 88% of the time they were doing all of the skills in the right order, in the right time frame, which, the piece that's missing right now is we don't know how that's translating to performance in a real delivery room resuscitation, right? This is just a simulated resuscitation. So that's the next step, is to see what the team can do in real resuscitations. But it seems like the deliberate practice over time has really dramatically improved the ability to get these scores closer to where they need to be. We also tracked efficiency of, really specific important skills. So like putting the EKG leads on the chest to know what the heart rate is. So in the on-site baseline, it used to take 4 minutes and 19 seconds for someone to do that. After the simulation sessions in the last one, it was down to 49 seconds, so 5.3 times faster. Getting a definitive airway, meaning intubating the apneic baby, that was taking over 11 minutes before. Now it's down to 4 minutes and 30 seconds. And then giving epinephrine if the heart rate is too low was 14 minutes before, and now it's 9.5 minutes. So really, really substantial improvements in this one hospital with multiple delivery room teams. So what we want to do next is we want to find a way to replicate our experience in the one hospital across multiple hospitals. So this is what I've been working on like crazy. This is due May 31st. It's an R01 grant, and it's a technology development grant to reduce healthcare disparities. And so what we're going to pitch to them is this innovation thing that we've worked on. So let me see if this can switch over. Danielle, do you see the baby, the hologram moving?
It's a white screen right now, Alexa. I don't know if it's
white screen. Okay,
yeah.
Let me just stop share because I just want to show this. This is so cool.
Yeah.
How about now? Do you see a baby moving?
Yes.
Okay, cool.
Hello, baby.
So this is Holo Baby. So this is a trademarked innovation. And basically what it is a hologram that is superimposed on a low fidelity, inexpensive mannequin. So instead of spending like $50,000 on a mannequin for every single rural hospital, which is obviously cost prohibitive, what we can do is spend like $6,000 on a very simple mannequin. And then people wear HoloLens, like Microsoft headsets, and they're looking at that simple mannequin, but they're seeing this hologram. And so the way the hologram moves, and you can scale things, so you can change how its eyes are open or closed, or like its muscle tone, so you can make it stop moving and just kind of lay there flat as a pancake. And that gives a much more realistic experience than just, the super expensive mannequin that, it has heart rate sounds and its lips can turn blue, but it certainly doesn't move and it certainly doesn't blink its eyes like this is. So let me go back to the talk here, if that will work. So yeah, so that's what the Holo Baby is. And basically Danielle, did that switch back, by the way?
Yes, it did.
Awesome. I love it when technology works. So what we're proposing to do for this R01 study is a randomized non-inferiority cluster trial. And so we're going to take 8 hospitals in our catchment area. 4 of them are going to be randomized to the high fidelity, like the old simulation that we did at that first hospital to show the improved adherence rates. And then 4 hospitals will get the Holo Baby experience. And we're going to compare to see whether, the hope is that the people doing Holo Baby have the same or better performance than the ones who have the high fidelity. And then we will also measure, aspects of like how the team works and the communication as secondary outcomes. And then the aim 2 of this grant is really exciting. It's all about implementation science and making sure that the way that this is rolled out at each hospital is very standardized, so that we're sure that if the hollow baby isn't working as well, it's not because we kind of did something different at one hospital, or, some kind of incidental thing affected the rollout of it rather than the actual technology. So just, kind of end with a picture. So this is my hospital here at Maine Medical Center, and my NICU is right on this level here. And I'm kind of often at my office is in a little corner, not near a window, but I kind of think of this as the epicenter of Maine, kind of like the, kind of hub of all of this. And these are all the community hospitals that I have existing relationships with through telemedicine. And then we've built, we're building, if we get this R01, all of these relationships with Northern Light Eastern Maine Medical Center. Through research, I have the relationship with the University of Vermont. We're building, hopefully soon, a relationship with the Elliott Hospital and with Dartmouth. And pretty soon, we have this whole catchment area of the whole, Maine, New Hampshire, and Vermont kind of top tier of New England. And ultimately, our goal is to improve the care delivered to babies, so that nobody misses an opportunity to have the best therapies possible. And I often end technology talks with this slide just because it cracks me up every time. And I think open to questions.
Oh my gosh, can you guys see why I call her a unicorn? What a phenomenal use case, both from a clinical and then leveraging that for the, the educational pieces, and now the new innovation with Hollow Baby. It's just such an amazing program, and we're so appreciative of your passion, and we so hope that you get the opportunity to expand access to this incredible service. I know, right? We do have at least one question in the Q&A. Aria, do we just typically read them out loud, or do we want to unmute folks?
It's just typically read them out loud.
Okay. So Elise asks, this is a great question. I'm excited to hear your answer.
Great question. Yeah.
We are in a rural community with a high rate of home births. If home births are common in your area, how do you communicate with those providers, or do you wait until the baby is seen at the rural hospital following that problematic birth?
Yeah, so that's a very interesting question. And our practice here is that baby hits the ER and, basically gets sent straight to the NICU. And that's when the teleconsult happens. I think to open it up to midwives delivering home births is more medical legal responsibility than I'm willing to take on. Just because you don't have the pieces of the decision making, right? Sometimes you don't even have APGARs. You definitely don't have cord gases. This, from the home births that I've taken care of in this situation, we often wind up cooling the baby simply because we really don't have information that we feel we can trust about what was going on around the time of the delivery. So yeah, hopefully that's a decent answer. Tricky.
Yeah, for sure. Second question from Carolyn. Is there a gestational age limit start point for hypothermia treatment currently?
So the rules are, according to the clinical trials that were published in the early 2000s, 36 weeks and above. Our guideline at Maine Medical Center is 35 weeks, except when you're 34, because I've cooled 3 34-weekers and I've cooled 1 33-weeker. When I cool off protocol, it's in a slam dunk case where we know that something definitely happened, like a uterine rupture, for instance, was the 33-weeker that we cooled. The baby has to be over about 2.2 kilograms to be big enough to tolerate the therapy. And we only do it with informed consent from the family so that they understand that we're off protocol, that this isn't studied, but that we believe it's safe and we believe it's in the best interest of the baby. And knock on wood, I've had no complications that, were a problem at all for those families. So, and all 4 have had normal outcomes. So it's really, it's interesting, but by the book, the answer is probably 35 to 36 weeks.
Great. Other questions? We've got everything in the Q&A so far. Is there anything else that you would just love to share with our audience here?
I mean, I think that, there weren't very many good things that came out of the pandemic. But I think that the expansion of telemedicine has been tremendous. I think what hasn't kept pace with the ability to use telemedicine is the compensation for telemedicine. And so that's part of the advocacy that we're planning in the HRSA grant, is that when I make the decision, and I do take a tremendous amount of risk on my decision-making and on my shoulders, I feel like the insurance companies are the ones who benefit, because they're no longer responsible for the ambulance ride, the neonatal ICU hospitalization. And then we might, maybe if we're lucky, get $35 for the telemedicine consult. And that just feels really not fair, because I'm working nights and weekends for free to keep this program running for the good of patients, which is really, really important. And the insurance companies are, in my opinion anyway, probably laughing all the way to the bank, because their expenses are going down with somebody else assuming the risk. And so I think there needs to be, I need help with this. And certainly, Danielle, if we get the HRSA grant, we'll be banging on your door about, at a state level, or even, this is a national talk, right? So at a federal level, there are lots and lots of small hospitals, rural community hospitals, that are sending babies. And there's a lot of money to be saved if there are other places like mine that were cooling babies unnecessarily. But there's got to be a compensation model to make it worth it to run a telemedicine program.
Absolutely. For, traditional reimbursement, or even, more innovative reimbursement models, or certainly we know that there's such a huge issue with healthcare workforce across all sectors,
Right.
really. But think about not having to put those a lot of rural communities, regardless of whether we're Maine or across the country, have one ambulance, right? And so putting that on the road with this baby is detrimental to the rest of the community. And if you don't have to do that, it's this snowball effect of either
resources
negative or positive impact. Yes,
Yep.
absolutely. So it's really meaningful to be able to have these programs and resources. So
I have all this data, and I don't know how to analyze it on a economics sort of do you know what I mean? And so, if anybody on this call knows about that, I can put my email in the chat here. Would people see the chat, Danielle?
Yes, as long as you change it to showing everyone, yes, panelists and
I don't have
if you're comfortable with us sharing your email, we certainly can do that.
Send it out, because I don't have the option. It's just panelists for me. But I think if anybody has experience with how to sort of write, create those arguments, and I would be all ears. It looks like Elise has another question.
She does.
Meet much resistance in initiating rural partnerships? I would say absolutely the opposite. People that I work with have been desperate to have help with these tricky babies. And it's actually, the resistance came from the neonatologist. This is what's so funny. So the neonatologists in my hospital are in general more risk averse than I am. And so there were very significant concerns about well, if you do a teleconsult, do you feel comfortable leaving the baby in the community hospital if it doesn't automatically meet criteria? And if it changes, how are we going to get there fast enough to start the treatment? And so what we initially did was we brought every baby we did a teleconsult on, we brought them anyway. And after about 6 months of that, everybody was like, okay, this is ridiculous, right? And so we then would leave the babies in the community hospital, because it became more clear over time, kind of how babies fell into which of those categories, the mild, moderate, and severe. Things have transformed from 2018 to now so significantly that the neonatology group here at Maine Medical Center has their own program on using the same cameras that I built. And they're now providing telemedicine consults for respiratory distress, dysmorphic features, all sorts of hey, what's that skin rash on your arm, for newborns in all of these community hospitals. So they transitioned from hey, we don't think we really want to do this, and you do all the talking and you take all the risk, to now they're running a parallel program, which I just think is amazing. And in the rural community, to go back to Elisa's question, they are thrilled because, again, it's another way that they're having backup of common problems, and things that they need help with, but they didn't necessarily want to send the baby by ambulance for. So
awesome. We have another Elise, very common name on today's webinar.
Cool.
And this is wait, this question: how do you staff this program? Another reason why you're a unicorn, to ensure you have coverage if a call comes in.
So this is the staffing model. This is my iPhone, you guys. And I have literally been on call continuously since 2017 for this research project. I'm in the process right now of training my 4 pediatric neurology partners to be able to also take these calls and start to shoulder the burden, with me, because as it transitions from research to a clinical program, obviously it's ridiculous for one person to have done it as long as I did, but I'm very, as you can tell, very passionate about the babies. So that's going to be the new model, and in conjunction with the neonatologists, who they're the folks who are actually taking the call from, the call from the rural community hospital comes to Maine Medical Center, to our, call center. And then the call center contacts the neonatologist, and then the neonatologist contacts us. So it's not like I'm necessarily fielding phone calls from the community hospital all the time. It's mostly getting a text from a neonatologist saying, hey, we need you to do a teleconsult. I call them, they give me the rundown of what's going on, and then I log on and do it. So I think that's what's made it sustainable as a one-woman show for this long. So anyway.
And I think maybe one final comment, because I think I need to turn it back over to Aria to just kind of wrap us up here today. So they just said, this is so exciting. Thank you for your work and insight and time and energy. And we are lucky to have Dr. Craig in our region, and to have her sharing here with everybody today. Thank you all for joining us. We really appreciate your time. And with that, I think we'll turn it back over to you, Aria.
Thanks.
Thank you, Danielle. I'm just going to bring up the closing slides here. So just a reminder that our next webinar will be held on Thursday, April 20th, and that will be on social determinants of health and value-based pay. And lastly, we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar. Your feedback is very valuable to us. Thank you again to Dr. Craig for presenting today, and to the Northeast Telehealth Resource Center for hosting today's webinar. Have a great day, everyone.
Thanks all. Take care.
Thank you. Bye.